Hello, my name is Cynthia Koo and I'm a regional anesthesiologist at Stanford Hospital and a member of the Division of Global Anesthesia. I have volunteered with the ASA Global Humanitarian Outreach Program at the University of Rwanda in Kigali and with FAME Africa, a small nonprofit hospital in Karatu, Tanzania. This lecture is going to be about the use of regional anesthesia in resource-limited settings. The learning objectives for this talk include discussing the benefits of regional anesthesia in resource-limited settings and tips for developing a sustainable regional anesthesia program. Many of you are probably aware of the benefits of regional anesthesia, including intraoperative and postoperative analgesia, reduced perioperative morbidity and mortality, lower anesthetic requirements and subsequent decreases in side effects with improved patient satisfaction. The reduction in opiates is important, particularly given the current opiate epidemic in the United States and in the setting of drug shortages like the recent hydromorphone shortage. In terms of hospital resource utilization, the patients require shorter recovery room times and have lower hospital readmission rates. We are routinely sending home patients with catheters that otherwise might have stayed in the hospital for pain control, such as our ankle fractures. With all of these benefits, the UCSD group found that in a large database analysis, that of the 25% of outpatient cases that were amenable to blocks, only 3.3% of those patients were receiving them. And I believe this can be improved through education not only on how to perform blocks, but on how to develop a regional anesthesia acute pain program. An additional benefit during this present COVID-19 pandemic is that regional anesthesia can reduce aerosolization from intubation, as most extremity procedures can be done with just the nerve blocks and sedation rather than general anesthesia. These data are from one of my favorite studies by MSF in 2016, looking at the outcome of their cases over a 6-year period and over 75,000 anesthetics. Their main anesthetics were spinal and general anesthesia without tracheal intubation. The overall perioperative mortality rate was 0.25%, but notably their mortality rates were higher for general anesthetics than for regional anesthetics. The summary commented that regional anesthetics were used in only 6.9% of cases, despite favorable safety profile and minimal infrastructure needed in terms of equipment and medications, probably limited by the need for a proficient level of expertise to perform them effectively, an area for potential future focus. This inspired me to work on bringing sustainable regional anesthesia solutions to our global anesthesia partner sites. Let's take a step back and think about the finite resources, both here and abroad, which are time and money. The reality of medicine, especially in low-resource environments, is that these factors place constraints on what is feasible. In the case of regional anesthesia, not only does it provide better patient outcomes, but regional does well in the metrics of time and money. In a study of carotid endarterectomy surgeries, regional anesthesia had a significant cost savings of 30%, decreased operative time of 34 minutes, and shorter hospitalization of 0.8 days. Regional also had better neurologic outcomes and fewer complications, which is priceless. Comparing spinal and general anesthesia for femur fractures, the spinal took 4 minutes longer to administer, but saved 29% of the cost. When the block is used for analgesia rather than anesthesia, such as a transversus abdominis plane block during a laparoscopic cholecystectomy, they found similar duration of anesthesia and surgical time, but a 17% reduction in the cost of desflurane. Now realistically, in resource-constrained settings, they're not using desflurane, but in Rwanda they frequently have oxygen failures, and the use of regional anesthesia could reduce the morbidity and mortality associated with those oxygen failures. At this point, hopefully I've convinced you all that regional anesthesia in resource-limited settings is potentially beneficial. The next step I considered was whether to focus on teaching nerve stimulation or ultrasound-guided peripheral nerve blocks. In the current era, ultrasounds are becoming increasingly prevalent throughout all areas of anesthesia, from bedside lung exams in ICU COVID patients to placing lines in neonates. Although the ultrasound has a higher initial purchase cost, the investment is balanced by the cost savings from increased efficacy, shorter onset, and higher success rate of surgical anesthesia. In a study from Denmark of 1,000 foot and ankle surgeries comparing nerve stimulation and ultrasound, they found greater efficacy with ultrasound, 94% compared to with nerve stim, which was 79%, shorter physician and nurse time, which is a scarce resource, and combining the efficacy and cost per block, ultrasound had better clinical outcomes and lower cost compared to nerve stimulation for the sciatic block. The limitation of these data include a lack of data in low resource settings, and also the opportunity costs and the training costs haven't been factored into the calculations. Even though we, as regional anesthesiologists, think that blocks are great, sustainability can only be achieved by buy-in from the OR administration, surgeons, nurses, and patients. And this involves building relationships over time and demonstrating repeated success. So when starting a program, communication is key, as well as choosing optimal candidates and setting expectations appropriately. Initially, the learning curve will take time, but as the process improves, it'll become more efficient, particularly if the blocks can be placed preoperatively rather than intra-op, which leads to the next section focusing on specific goals in developing a sustainable regional anesthesia program. Regional anesthesia requires minimal supplies, which makes it feasible for low resource settings. At its most basic, you need a means to identify the nerve, which is the ultrasound, needles and local anesthetic, and a means to perform the procedure in a sterile fashion, including gloves, skin prep, and an ultrasound probe cover. There are several companies that make block needles, and I won't go into them during this talk, but the overall goal is to use a needle that's echogenic and short beveled, which is less likely to penetrate the nerve tissue. In our own practice, we frequently place nerve catheters, which can be done through a TUI needle similar to an epidural, or catheter over needle like an IV. The local anesthetics vary in terms of their pharmacology, but also in terms of their cost. Commonly used in our practice are lidocaine and bupivacaine, which cost about $2 to $3, as well as mepivacaine and ropivacaine, which cost more on the order of $15 to $20. So I would recommend bupivacaine in resource-limited settings, as well as lidocaine if needed to speed up the onset, for example, if the block is being performed in the operating room. Ideally, the block would be performed in the pre-op area to allow it to set up and to reduce the cost of intraoperative time. This also helps gain surgeon support as blocks can be performed while the operating room is turning over if there isn't a separate regional anesthesiologist. In Rwanda, we were able to set up an area in the pre-op area with a monitor and a designated cart with locked drawers. Having a separate designated area improves the efficiency because the cart and ultrasound don't have to be moved for each patient, and it helps with safety because the area is stocked with emergency medications including intralipid. Because of their care team model, Rwanda was well situated for having the anesthesiologist leave the OR to perform the next block while the non-physician anesthetist monitored the patient. Another aspect of sustainability is documentation and billing. Prior to the block, the patients are consented, then everything is set up for the block and a timeout is performed immediately before block placement. For the procedure, note, ours is set up to be auto-populated for single shot or catheter, reducing the amount of time required for documentation. I'll highlight that this is important to document pre-existing neuropathies for medical legal reasons, and that the ultrasound image was added to the chart for billing compliance. For follow-up after block placement, the patients who receive single shots are called the next day to make sure the block has resolved and there are no complications, and the catheters are called post-op day 1 to answer questions and then after the catheter has been removed. The inpatients are followed by our acute pain service who manage the epidurals as well, and all of the communications are documented in the patient record. In addition to the infrastructure, starting a regional anesthesia service requires expertise. The American and European societies for regional anesthesia have published joint training guidelines. The didactic component should include 4 major categories. 1. Understanding device operation. 2. Image optimization. 3. Image interpretation. 4. Visualization of needle insertion and injection. In our training program at Stanford and the Global Anesthesia Partner Sites, we address ultrasound image generation and optimization during regional anesthesia workshops. Often locals are hired as live models for these workshops, so at Stanford we have medical students, and in Tanzania we hired a security guard. The literature on regional anesthesia education shows the value of simulation to help with the steep learning curve of this highly visual spatial field. We have used 3D printing to design our own ballistic gel simulation phantoms for ultrasound-guided needle training. Our phantoms are 5% the cost of commercial phantoms and can be recast to remove the needle tracks that develop over time in the gel. In addition to the technical skills of being able to visualize the needle and reach the target, it's important to have a full understanding of anatomy to ensure safety and efficacy. Identifying target structures as well as potential hazards like vessels and other nerves comes with practice. While most of this practice happens in patients, we wondered whether it would be possible to simulate the practice, visualizing anatomy using images from a variety of patients with anatomical variations. So we've developed an online platform on the Learnly website for sonoanatomy with images and questions of increasing difficulty. The goal is to increase familiarity with the anatomy and potential variations prior to and in conjunction with patient care. To recap, regional anesthesia improves patient satisfaction and outcomes. Regional has a favorable safety profile, including in low-resource settings, and it can be cost-effective and time-saving. Developing a regional service requires minimal infrastructure, and deliberate practice and simulation, as well as feedback, can advance those skills. Here are a couple of review questions for this lecture. The benefits of regional anesthesia include all of the following except A. Decreased anesthetic medication requirements, B. Improved patient satisfaction, C. Improved surgeon satisfaction, D. Faster recovery room times, and E. Fewer side effects. The correct answer is that regional anesthesia does not improve surgeon satisfaction, but it does improve patient satisfaction, side effects, and recovery room time. According to the 2016 MSF study of resource-limited settings, which of the following anesthesia types has the highest mortality rate? A. General anesthesia with tracheal intubation. B. General anesthesia without tracheal intubation. C. Spinal anesthesia. D. Regional anesthesia. Or E. Combined anesthesia. The correct answer is A. In this dataset of low-resource settings, the highest mortality rate occurred with general anesthesia with intubation, about 1.7%, versus, for example, regional anesthesia had a mortality rate of 0.06%. For more information, check out the following references.